So thank you very much for giving me the opportunity to give a presentation on the role of the GALAD score for HCC early detection in NASH patients. And actually, as we all know, that hepatocarcinogenesis is a multifactorial occurrence that's not only depending on a single event, but it can be caused by chronic hepatitis, alcohol, NASH, and many other etiologies leading to cell necrosis and a cycle of regeneration leading to chronic liver damage and finally to liver cirrhosis. And during this very complex interaction, we have the formation of regenerative nodules that will then transform to dysplastic nodules, early HCC and advanced HCC. And I think we all agree that it's of high urgency to detect the HCC already at very early stages. So we have to have some tools to identify the transformation from dysplastic nodule to early HCC at the point where we still have curative treatment options. We know that the HCC is always a worst case scenario. We know the incidence almost equals the annual mortality. And we also have to keep in mind that worldwide about 15 to 20% of all HCCs are occurring in non-cirrhotic livers. So frequently HCCs are diagnosed very late when curative strategies are no longer possible. And this results in a low resectability rate. And we know that HCC in early stages have a very high 5-year overall survival. So this is the population that we want to detect. And in more advanced stages and palliative therapy settings, we only have a median survival of 1 to 2 years. So to conclude, we have a very urgent need to improve the early detection. So there was a very recent study presented in last year in JHEP that examined the benefit of HCC surveillance. And this study is a very, very large study that was utilizing articles from a 6-year period and was investigating the surveillance benefits of HCC surveillance and the harms that can be caused in patients with cirrhosis due to the surveillance. And all in all, 59 studies were utilized and included 145,000 patients. And the result of this analysis was that we have an improved early stage detection, thus a higher receipt of curative therapy options and a higher overall survival with a hazard ratio of 0.67. So it was very advantageous to perform surveillance in the patients. And we, on the other hand, have only very little harm to the patient. Unfortunately, there still is a big lack of data what surveillance can harm for the patients financially or psychologically. But all in all, only in 8.8 to 25% of patients, we had very mild severity harms due, for example, to irradiation. And so the study could conclude that HCC surveillance was associated with improved early stage detection, potentially curative treatment strategies, and prolonged survival, and that the semi-annual surveillance intervals were associated with improved early HCC detection and survival. Few studies examined the surveillance outcomes in patients' population after sustained virologic response in chronic HCV or in fatty liver disease. Therefore, future studies are warranted here, and very few studies characterized surveillance-related harms, although available data suggests that the surveillance-related harms are very low in severity. So there is a big difference in the international guidelines concerning the HCC surveillance. So we have the German guideline that recommends surveillance in all liver etiology, cirrhosis etiologies, and also in chronic hepatitis B at a page B score of more than 10 or in advanced fibrosis. And the recommended procedure is ultrasound with or with AFP every 6 months, and ultrasound quality standards are required. The European guidelines have similar inclusion for surveillance, but here we can already see that ultrasound biannually is recommended only without additional utilization of AFP. Then the American guidelines, again, they recommend ultrasound with or without AFP. Then the Asian guidelines, they recommend ultrasound and AFP every 6 months. And then we have the Japanese guidelines, and those are very different from all other international guidelines because they recommend not only ultrasound, but they also recommend AFP in combination with AFP-L3 and DCP biannually. And then they even have a very high risk stratification group with cirrhotics that have chronic hepatitis B or C. And in those patients, even surveillance every 3 to 4 months is recommended. So what is the potential benefit of the surveillance? We can see here in the left hand, a German study from Weinmann et al. And they compared the survival of HCC patients over the time from 1998 to 2003 and from 2004 to 2009. And there was almost no difference in the survival in this long period of observation. In comparison, on the right hand, we have data from Japan. And here you can see that over the course of time, from the 80s to the 90s to the 2000s, the overall survival was continuously increasing. And so the median survival in Germany is only about 1.5 years, and in Japan, it's even 4 years. So in Japan, we have a successive improvement of the treatment over the decades, and curative treatments in Germany is only possible in 1/3 of the cases, while in Japan, in 2/3 of all cases, curative intended treatment options are available. Additional benefit or the comparison between HCC surveillance, which is performed by ultrasound only. And you can say that only 4 in 10 HCCs are detected at early stages if you do ultrasound alone. And the sensitivity of ultrasound alone is only 45%. And if you add ultrasound and a alpha-fetoprotein together, then your sensitivity increases to 63%. And this is very big data. There was a surveillance period of 2 reviewers that searched Medline and Scopus for about 25 years of data, and there were 32 studies comprising 13,000 patients included, and they characterized the sensitivity of imaging with or without alpha-fetoprotein, and the ultrasound alone detected HCC with a higher level of specificity than ultrasound plus AFP measurement though, and CT or MRI imaging-based surveillance detected HCC with a 84% sensitivity. So the editor concluded that the finding is very clear that ultrasound has a far lower sensitivity than ultrasound plus AFP. And on the other hand, the conclusions are not only based on non-randomized observational studies with indirect comparison and a lot of selection biases. And of course, we have potential confounders here, but also these data serves as a strong signal to potentially change the professional society guideline recommendations to even include alpha-fetoprotein with ultrasound as a recommended screening strategy. So this was published in Gastroenterology in 2018. So what would be the ideal biomarker to perform efficient, cost-efficient and time-efficient screening? So this biomarker should be readily available. It should be reproducible measurement results, should be cost-effective and as accurate as possible. So the problem is that many biomarkers were studied in HCC, but the true challenge is, as we already learned from a lot of my previous presentators, that the molecular heterogeneity of the HCC makes this biomarker screening very difficult. So in AFP, we have a controversy between the guidelines and the problem of specificity, especially in hepatitis C. We all know that chronic hepatitis C that's replicative leads to elevated AFP levels. And on the other hand, 40 to 50% of all HCCs are negative for HCC, and cutoff values are not uniform. Generally, it's recommended 20 nanograms per ml. So there are also different other biomarkers. If we measure our AFP in our laboratory, it's the combination of the subtypes AFP L1, L2, and L3. And there is the special feature of the AFP L3 that there's a fucosylation that's binding the lens culinaris agglutinin of HCC, and thus the AFP L3, in contrast to the whole AFP together, is specific for hepatocellular carcinoma. And then in addition, we have the DCP, the des-gamma-carboxyprothrombin, or PIVKA2, and this marker is detecting some vitamin K deficiency that's arising during the hepatocarcinogenesis. So there are 3 biomarkers available that are CE marked and in the United States FDA approved as automated assays. They are available as microfluidic chip assays and can be done during laboratory routine. So there was the further approach then after these 3 biomarkers were established, that also a special score was developed by Philip Johnson in the year 2014, where gender and AFP as independent risk factors for HCC were included to the score. And the pilot project was on a British cohort where there were 300 HCCs versus about 300 controls with cirrhosis. And there they could see that there was a high diagnostic performance in detecting even early stages of HCC exclusively by user-independent methods. So we here see in blue, this is the GALAD model with an area under the curve, under the ROC curve of 0.96. And so it was significantly better than the biomarkers used alone. So this was just a rather small cohort. So we also tried to reproduce these data in a German cohort, and there is a little different to the previous project. We also made combinations of the different markers, and what is I think remarkable, that if you combine all the 3 markers together, you have a significantly lower area under the curve as in comparison to GALAD, and which is important also that this is in the BCLC stage 0 and A. So there you can see you have a very high level of performance in detection of early HCCs. But this is, of course, just retrospective data at this moment. So at the same year, there was a prospective study of screening cohort of patients with hepatitis B. And these patients, you can see over a period of more than 35 months, that all the 3 biomarkers were measured individually. And you can see that the AFP level is very constant during the entire period of measuring. And here at the time point 0, that was the time of HCC diagnosis in the patient. And what you could already see, that many months before the HCC could be detected by imaging procedures. The DCP and the AFP L3 were already rising, but however, this was a very small patient collective, so not that representative at this time point. So furthermore, a bit later in 2016, there was a very large international validation of the GALAD score. Then that was an international multi-center project with many centers from England, Japan, Germany, Hong Kong, and there were cirrhotics, HCC patients, and healthy controls included. And this study was done in a very detailed manner, because there was also taken into account if patients that had HCV, if they already achieved sustained virologic response or not, or if they were on HPV treatment during the screening period. I think this is a very important factor that very frequently is not included in these studies. And also there was a comparison between cirrhotic HCV and cirrhotic hepatitis B patients. So all in all, more than 1,000 patients were included for the groups. And the result is that the GALAD score is very similar in its diagnostic performance globally. You could see here a German group and a Japanese group. So you can see independent of the ethnic background of the patients. Here in red, you can see the GALAD score again is significantly superior compared to AFP, AFP-L3 or DCP alone. So this was a publication done by Philip Johnson in 2016. Then in 2019, another group was investigating maybe you could combine the ultrasound surveillance with the GALAD score. And this is what they had done. They had a validation study, American cohort with a single center cohort from 111 HCC patients and 180 controls with cirrhosis or chronic hepatitis B. And you had a multi-center cohort with 233 early HCC patients and 412 cirrhotic patients from early detection research network. And in this study, you could see that the area under the curve of the GALAD score was 0.95, and the OROC of ultrasound was 0.82. The problem, as we all know, is of course the strong heterogeneity of the quality of ultrasound that is provided at the practitioners. So at the cutoff of 0.76, the GALAD had a sensitivity of 91% and a specificity of 85%. So now you want to know the area under the curve of the GALAD for early HCC detection. It's still 0.92. And this is the most important fact, that if you combine the GALAD score plus ultrasound, and they called this the GALAD score, then the area under the curve was improved to 0.98 in this single center cohort. So the GALAD was better than ultrasound in HCC detection, but combining both is even giving a further improvement. The problem that we are facing nowadays, though, is that we have a very strong epidemiological shift, and I think this is during all continents now, that we have a strong increase of metabolic syndrome and its hepatic manifestation of NASH. And the problem that we are facing is the poor possibility to perform ultrasound surveillance due to the anatomic specifications of these patients. And on the other hand, you have a high proportion of NASH patients developing HCC even without underlying cirrhosis. So similar to the hepatitis B patients that do not need the cirrhosis as a prerequisite of hepatocarcinogenesis. This is also shown in the American Transplant Registry that we can see here for data from 2018 from UNOSI, and they checked more than 170,000 patients in their study, and you could clearly see a strong dip of the prevalence of HCC caused by chronic hepatitis C due to the DAA treatments that were available from 2014. This is very remarkable, but on the other hand, here in purple, you can still see that the NASH is still increasing, and I think the new data that we have already crossed the hepatitis C, so NASH will be one of the reasons for the increasing incidence of HCC based on fatty liver disease in the future. So the early diagnosis of HCC is of crucial importance. So then we investigated the biomarker-based HCC diagnosis in NASH patients in a multi-center study. And here, this was the first study to examine GALAD in only NASH patients. We had 8 centers participating in Germany, and we could include 345 patients, 121 of them with NASH HCC, and 224 patients with NASH only. And there are 2 things that are showing why the GALAD score is including gender and age. You see the HCC group is about 20 years older than the non-HCC patients, and you see a much higher proportion of male patients compared to the non-HCC group. And what is another independent factor that should be investigated a lot more in future is that in the non-HCC patient group, only 38% of patients had a diabetes type 2, while in the HCC collective, this number was 70%, so remarkably higher proportion of diabetes patients in the NASH HCC subgroup. So what was the result? We tested the marker combination in the GALAD score again against the single biomarkers, and you could clearly see that the GALAD achieves a significant improvement over the single markers with an area under the curve again from 0.96, and this clearly shows that the GALAD score can be used as a screening test. However, this was just retrospective cohorts. So we then utilized a Japanese prospective screening cohort to see how the performance is in the early HCC detection. And what you can see again here is a time frame of 6 years. At the time point 0, the HCC was detected, and in the non-HCC group, you see that the GALAD score is staying quite stable over the time course. But in the HCC patients, you can clearly see that the score is already significantly increasing in the patient group that is developing HCC. It was a group of 360 NASH patients and 30 NASH HCC patients developing HCC during the screening period. So what we can say that the hepatocellular carcinoma shows an increasing incidence with still a very poor prognosis. We have an improved early detection that is critical for application of curative therapies. We combined use of available markers enables the detection of HCC with significantly improved sensitivities, and the combination of markers and ultrasounds provides additional improvements. So now I would like to thank you very much for your attention.